Very good evening to all. Thank you, Mr. President, for the introduction. And I thank Dr. Jolly, Sunita, and his team for inviting me for this program. And I'm very happy to say that as part of this program, the day on itself is my 13th lecture. I'm doing that this Jolly conference. So you know that diabetic food, the major problem is amputation, but there are a lot of complications for diabetes from your brain to the heart to the lungs to the kidneys to the intestines. But what is very, very important, but the causes complication is always peripheral disease and food problems. And diabetic food is a problem of almost 12 to 15% of all diabetic patients. So you all know that heard of Mamangam. Mamangam is a festival and a war which happened in Malabar. And always it was a fight between the one village people and somebody. And always the village people fight a single person was Jagawa. And because even though Jagawa is how much able and good fighter, they could never win the war because they are always alone. But look at this is Operation Sindoor. Overnight, we used all the forces as a big team and a big technology so that we could win the war. So diabetes food itself is a war to save our patients, save our lives. So the current problems are mostly multifaceted, including neuropathy, vascular disease, infections, gangrene, and chocolate food. And ultimately, a good number of patients end up in amputations, and a few unlucky will die of this. So the thing is that this shows the importance that no single person can manage all these problems. This needs a huge different type of specialists to look at different from the patient. So the targets of treatment are basically to prevent and manage the food infections, avoid recurrent infections, prevent ulcers, and always promote wound healing and manage the wound until ultimately prevent amputations. So ultimate management and target of treatment is to prevent amputations, but there are a lot of challenges. Challenges are from the medical side, the patient side, the family side, social side. The patient side has neuropathy, vasculopathy, infections, etc. And the social, most of those long-term ulcers are recurrent ulcerations. They cannot go for social functions. Always they have to do regular dressings and wound care. That's also a problem. Patient will move out. Personally, the many patients are depressed, isolated. When we talk to the patient, they try to avoid marriages, avoid many family functions because of the ulcerations, discharges. So they need continuous psychological support for maintaining the family and their patient, their personal habitat. And of course, it's one of the costliest complications to manage. So we need different protocols, we need good algorithms to treat these patients, to avoid these complications, avoid these recurrences, and keep them in. So how can we do this? There are the many studies show that the multidisciplinary teams, which is called MDT, in diabetic food care, just like in malignancy, they could prevent a lot of complications and give very good management. So we have a multifactorial disease from infection, the neurological issues, vascular issues, and it has a lot of complex comorbidities. Many patients, when we come for the treatment, their kidney is affected, they have one or two stents heart, they have stroke or a TIAs. So these comorbidities are there, we have to manage these patients. And so it cannot be a single specialty disease, it's a multi-specialty disease. So the question is, how can we prevent it? So it's a vascular disease. We need many patients need vascular support to avoid long-term morbidity, and the team should comprise of podiatrists, which should see the patients regularly. They need to see the patient in the pre-ulcer phase, ulcer phase and post-ulcer phase. And the role of Q is very important as endocrinologist physicians. You see the patients regularly, you have to do comprehensive care, better control of diabetes and better control of sugar, and of course the vascular surgeons, because most of these patients lose their limb because of the poor vascularity. So vascular science is an essential part of this treatment, and we need support specialists like orthopedicians to change the shape of the foot and to do the weight different. Then wound care nurses, orthotists. So these are different specialists which are different in groups, which is need to involve the treatment of these patients. And always very important is they should have a perfect algorithm of references. One fellow who is treating the complication cannot treat all the complications. Whenever he patients the reference, it has to be referred as per clear protocols. It should not be the property of a single physician or a single surgeon, and there should be a leadership to maintain that patient coordination, and the family has to be involved. Their economics must be discussed, and the patient has to be discussed regarding the main problems. And this team should be require continuous training and continuous education to get the better training and the best output. And always, technology is very important. We need to have the best technology, the best, most modern technology to save our limbs. Because the last 10 15 years, we could bring down the level of amputations by multi-fold, and many patients are locking out with their limbs mostly because of this technology advancement. So always we should have a team captain who decide the patient has to treat. It's a good center, the team captain who should decide where the patient goes and who should treat the patient, who should be the patient. That should be there. That the answer numbers has to be decided. There will be clear of protocols, as I said earlier, and how frequent the patient has to come. As an uncomplicated food or a complicated food, what is the gap of the patient seen, and always the team should adhere to guidelines. There should be clear guidelines for that. So, most important part is glycemic control. Unless you control the blood glucose level, what happens is the food will be a loss of sugar like. So, the infection can concentrate there, the bacteria can concentrate there and produce severe infections. So, glycemic control is very important for the local food problems and also for the cardiac, the renal, and all. So that's very important. Our physician is very important in glycemic control, and every wound has to be seen by the physician or the psychologist. Any patient is coming to you for diabetes care just for to show him the sugar. At least in 3 months, you should see the food. It is not the surgeon or somebody else. If they come to a physician, they should have spent at least 1 or 2 minutes to see the food, look at the shape of the food, look for any ulcerations, or look at any change in the shape, or look at any bleeding or discharge or whatever it is. So that's very important. So once there's an active infection, it's a warlike. There should be referred immediately to some person, a surgeon, and the old addicted shoe that should be removed immediately. And the good infection control has to be achieved. Off-roading is very important. If you have the body weight on this food, there's a more chance of spreading infection from one point to other point. That's again increase the severity of infections. All the patients with the diabetes, particularly more than 10 years, always touch your finger on the Salvage and posterior whenever they enter and look for the pulses and compare to the opposite. If there is any change in this patient needs a reassessment, you can do a doctor, and these patients should be put on sulfosol and also that for better control, for improvement of osteoarthritis. Many studies have clearly proved that the sulfosol and the lorazepam combination have changed the outcome of diabetic foot and diabetic vascular. So that should be given to all these patients, and the cross-fitting can be added, but doesn't have much benefit for that peripheral arteries concern. So infection should be controlled on a clear protocol. We cannot start a higher antibiotics on a single infection, and the small infection means the higher infection is a higher antibiotic. So every team, every institution should have a protocol which antibiotic is to be started and when do you. There's a clear formal rule, that is, if a patient is seen by a physician or a dermatologist, and with a small ulcer, and you put on conservative management, if the ulcer is not improved from this area, when you see the patient ulcer is positive in the square, and if after 4 weeks it is again require a person that means patient is escalation of treatment. And that has to be referred to concerned person to avoid another amputation. So this can be achieved with a multi-specialty team where the different specialists see these patients in time and treat these problems. So advanced protocols are available and this should be taught in the whole team, and it is better to have a team discussion in between so that we can share the experience, they can share development in the management of diabetic foot problems. So that's very important. And the role of patient. The patient should be educated about the importance of caring the food, not treat the food, caring the food. We are spending more than 30 minutes or 1 hour or whatever it is for caring our face or our dress, but we are not spending 5 minutes to care about it. So what I talk to my patients is always look at their food at least a week. And if you're old or if your vision is impaired, get the help of your children or grandchildren so that let them see your food, let them feed it, and let them have a clear vision of your food. So that sort of support that they should get in the family, and that importance of that should be taught to the patient. Then only they can prevent this amputation fully when they identify the problems in the early stage. And family is also important because most of these treatments are very costly. They need long-term hospitalization, then long-term immediately with the patient. So this is all part of this treatment. So the family's role is very, very important, and family should be educated. And ideally, you have to identify one or two like this close to this patient who can take care of the patient. Then only this treatment is complete. So because amputation is a disaster for any patient. So there's a lot of proof regarding this. There's a lot of clinical guidelines that come up with regard to treatment of diabetic food from different countries, different centers. Many centers across the globe are doing this. So a lot of studies of meta-analysis show that there is a gross reduction in the incidence of amputations, the cost of treatment, and the wound healing by a multidisciplinary approach. So studies shows you can reduce amputation by 94%. It's a huge amount. You're saving 94% of limbs by just having a good team to treat rather than a single man approach. So we can increase wound healing by 75%, and more than that, hospital admissions can be reduced by 30%. The importance is for a physician with a long-term patients rather than early complication patients. Remember, if they undergo a major amputation, within 2 years, the other limb will get amputated, or the 50% die of the cardiac illness in 2 years. So you are losing patients also. So if you are looking at the number of patients also, you should have long-term patients. So for that, approach is very, very important. So there's a reduced amputation rate, improved healing, patient satisfaction, cost savings by a multi-approach, and have very good impact on the diabetic food applications. So these are studies from different parts. These Italian guidelines, they advise only multi-system approach for diabetic food management because they have clear evidence that this will change the outcome. This is from Singapore. They have a concept called Dream Clinic where diabetic rapid evaluation. They do not wait for an infection or somebody or something else. So there's a diabetic rapid evaluation, lower than amputation management. Dream clinics are set up in Singapore, and they shows they have a different better outcome in the diabetic foot care and reduction of amputations. So its role is very well defined, and vascular surgery is the most important part of it. This another study published, they showed that the Indian approach to management diabetic foot definitely that have a different outcome, so we can change the management. So there are a lot of guidelines for this. Most about the IDSA guidelines, they clearly says that diabetic foot is not a single specialty disease, or diabetes is not a single man's territory. There should be a team to manage, and the team should comprise of podiatrists, endocrinologists, physicians, young physicians, vascular surgeons, nursing staff. Everybody should see the patient for better healing and prevent complications. So it's now, just like a malignancy, I always compare diabetic foot with a malignancy. If you look at the CR rectum, with available treatment, they can live more than 10-15 years. I have patients. But for a diabetic foot patient, if you amputate them, Most of them will die within 2 years. So it's a much devastating disease than a malignancy. And more than these patients are savable and salvageable if we have a good approach to these patients. So there are a lot of benefits for healthcare system and for the patients. To summarize, this is very, very important for the outcome of these treatments. These are all great people of Indian cricket. And many, they are batsmen, they are wicketkeepers, they are bowlers, and they are very, very great people. But remember, they won all the trophies together. So if you have better achievement, be a team and build a team that can change the outcome of the food. So with that, once again I thank JPEF for giving this opportunity to talk to you. Thank you very much.
Thank you very much, sir. That was a wonderful presentation. Now we can ask the audience if they have any questions to ask. Yeah, sir. Thank you for the wonderful discussion, sir. Uh, my question is, most of the time, the diabetic foot infections, once it starts, it's been actively there for a long time. Many of the patients today, due to the various comorbidities that they are having and the pleiotropic benefits that is required in their patients, the SGLT2 inhibitors becomes somewhat of an automatic choice. But diabetic foot infection and SGLT2 inhibitors isn't it uh, a risk factor for a euglycemic ketoacidosis? What's your take on that? And when do you, in your personal practice, would love to restart an SGLT2 inhibitor in a diabetic foot patient? What is the grayscale that you keep?
That's a very tough question, just like. Mostly I reflect that such a risky tough questions to my endocrinologist or physician because my comfort is when the weight is under me. I preferably I go for plain insulin or some regular insulins. But if the patient's diabetes is not controlled, definitely I get the help of the physician on that. So usually I want involved in that very difficult management of diabetes. And of course, once the wound is healed, I usually refer back to the patient for control of diabetes. I don't, because I'm not an expert in managing diabetes, so usually I won't involve in the long-term management of diabetes. The other thing is immediately the hospital field. In fact, what we are lacking is the elective diabetic foot surgery. That is one thing which is lacking here today. Some centers are doing it, or Guardian is doing some work on that. We are also doing some work on that. But we need to see this food after that process heat, because most of the LCS are happening due to the change the shape of the foot and those different shapes are changing. So that has to be corrected. So for that, we are working on more. So that is to be promoted for all the diabetic foot patients for diabetic insulin management and other be able to cover those things. Frankly speaking, I'm not so good in that.
One more question. Sir, what is the role of, like, supposed you said no role in primary prevention. What about in secondary prevention? For example, a patient has gone amputation of grade 2 and next he may be getting an amputation below knee amputation or above knee amputation. Is there a role of equipment in preventing secondary amputations?
Around the cost has it's very good in the cardiac and renal or stroke or whatever it is. If the patient is not on a network, not hospital, start the hospital, the cardiologist on this, I won't start on this side. If I do a graft, bypass the graft, then I will start the hospital. Otherwise, rods of our group are better in maintaining the flow for the peripheral is concerned. So periphery is ecosprin we don't look for the first choice. And not studies is a better advantage using ecosprin just for the primary prevention of the diabetic foot problems. But definitely that's the best drug for the cardiac and renal problems. So personally I want to do is don't put the patient ecosprin alone for peripheral pulse issues. Better you go for a silososol and also when 2.5 milligram twice a day, that has shown some advantage over ecosprin or chlorpromazine.
Any other questions? So, on top of chlorpromazine, silostazol going, would that have an added effect? I've seen somewhere like on top of chlorpromazine giving silostazol as an add-on might do a better research.
Silosol has no role of chlorpromazine. It's a two different class of drugs. One is a phosphodiesterase 5 inhibitor, one is a similar actions. Also, the chlorpromazine is started by cardiologists or diabetologists in the same patients. Personally, as science, we don't put down chlorpromazine. Our prime choice is also sold 200 milligram twice a day with the raloxifene,